to be here. Fantastic initiative. And I'm so grateful to be part of this symposium. So yeah, my name is John Stevens, and I've been a nurse since 1980. And I've also morphed into being a sociologist, I guess. And I'm here today to present to you about lifestyle medicine and some of the initiatives that are available to us that actually promote the social determinants of health in very positive ways. My own acknowledgement of the traditional owners of Australia. It was a photograph I was allowed to take and show from a time in drought in Australia where fish traps were revealed for the first time since colonisation that were dated to be about 60,000 years of age. And for me, that is absolute acknowledgement that there was somebody here before the colonisers. So likewise, I'd like to acknowledge the traditional owners, the elders past, present, and emerging. I come from a university called Southern Cross University. I've also, as Priya said, was the co-founder of the Australasian Society of Lifestyle Medicine. And I work at Southern Cross University leading the Lifestyle Medicine Masters program up there. And I want to talk to you a little bit about the society, if you like, because it underpins the sort of activity that me as a nurse and others in healthcare have gone to, have dedicated, if you like, to trying to change the health system from a very linear, non-personalized illness system, if you like, to one of looking at the whole person and wellness. And to do that, one has to take in the social determinants of health. We just can't look at a linear disease model that most of us of my vintage were trained on, and most of our health systems are still based on. This has led to a World Lifestyle Medicine Organization, which some of you might be well aware of at the moment, with 55 nations now with lifestyle medicine organizations involved in that, which is quite a development. So we've come from, the need for this has come out of the idea that most of our healthcare was based on the majority of us being, when we're ill, was due to either trauma or infectious disease. And that was the case for most of the era. And our health systems, if you like, are still sort of built on that largely, both at primary care level and hospital level. But of course, everything's changed. We are now in an era where acute diseases are falling because we've actually got some control over them. Although with the event of COVID, of course, we are now sort of in decline there as well. But through public health initiatives, we largely got on top of the issues of microorganisms. Not entirely, of course, there's still a big role for that. But what came along was the chronic disease momentum. And around about 1980, there's a moment in time where chronic disease seemed to take off in the world. And most of that chronic disease was lifestyle related. That is, we were in control of producing this chronic disease outbreak. And it now accounts for about 80% of all visits to a primary healthcare practitioner, and also roughly those sorts of numbers of people winding up in hospitals, in our hospitals, in the care of nurses. And in the day of the infectious disease and the system that looked after the infectious disease, a short consultation with your doctor, a short visit to an outpatients department meant that, we could linearly treat that disease in a linear way, that we could know that was a pathogen causing a lot of it, that we knew that because we could take that pathogen out of someone and put it into somebody else, and they would get that disease. And then we could find ways of treating it with antibiotics, or through surgery or other mechanisms to treat it. But with chronic disease, which is now 70 to 80% of the diseases that we are dealing with, there is no one cause. There are lots of determinants. We can't take diabetes out of one person and put it into somebody else. It's a whole of a social event that has brought the rise of these chronic diseases together. And it requires systems thinking, not linear thinking, not disease, cure, out the other side. We now have to think in systems. And a lot of those systems are, in fact, social determinants type systems that we're thinking about. And this, I don't expect you to be examined on this slide when we finish, but it is an example of all the things that go into thinking about what we need to think about in order to sort of get on top of a chronic illness. And out of this kind of systems thinking came the need for an approach, which we now call lifestyle medicine. It had many other names to begin with, but it's coalesced around the world as lifestyle medicine. Whether lifestyle medicine is the right word to determine it, there's lots of debates about that, but nonetheless, that's what we have at the moment. Within lifestyle medicine, we have a systems approach which looks initially at 6 pillars of evidence. So when we are working with people and patients, we're looking at nutrition, physical activity, stress management, sleep, substance abuse or misuse, and healthy relationships with people and the environment. That's the framework with which we work and develop new knowledge and skills and evidence to move forward into this wellness paradigm, if you like. Because so many of us as clinicians are working at the bottom of this waterfall, for want of a metaphor, that we are cleaning up, we are patching up people who are now coming to us with so much of this chronic illness. And our tools have been very, very limited by the systems by which we work in and possibly the education and skills development that we've had. And it's no one's fault, of course, it's just the way things have evolved. And as clinicians, we know more than just patching people up at the bottom. And so in lifestyle medicine, we were thinking, well, what is it? What is that extra thing? And it's a far more reaching view of health than just patching people up at the bottom. And this slide, if you like, is derived from Rose's hierarchy of causality, and we've adapted it a little bit. And here you can sort of see where most of us work, which is if we're clinicians and nurses and primary healthcare workers and hospital workers, we work down this end, treating these diseases, managing these diseases of lifestyle. Diabetes, for example. And we know there are risk factors involved in this lifestyle medicine, sorry, in these diseases. But as clinicians, we're here treating and managing this, and we don't have a lot of control. We have some, but not much control over what happens at this end. We know, for example, that a major risk factor for diabetes is obesity. But what do we as clinicians, we probably know a lot about how to manage that, but in our day-to-day work, how do we implement this? And how do we sort of work back upstream to do that? And once you start sort of peeling back that onion of upstreamness, it becomes even more interesting, doesn't it? Because obesity, so we ask the question, what's the cause of obesity that leads to diabetes? Well, we know from our science, and we collect a lot of science from a lot of different professions. So one of the beauties of lifestyle medicine is that we are integrating lots of good evidence into practice. And it's not just, it's evidence from lots and lots of disciplines that might have otherwise sat on the shelves because they're good science, but they haven't found ways to integrate it into practice. So we now in lifestyle medicine take that and take it and see how we can put it into practice. And we have great examples, great evidence to say that, well, obesity, we know from the evidence now, is lots of upstream or proximal downstream causes for obesity, probably to do with the way we're eating, the way we're inactive, possibly the way in which, in this case, we might be misusing substances, which is leading to sort of low activity. But certainly we know that sorry, I've gone too far. We know that diabetes related to obesity, we know at least that it's diet inactivity in action here. So what's caused the diet and the poor diet and inactivity that leads to obesity, that leads to type 2 diabetes? Well, let's go upstream a little bit further, and it's linked into the evidence that's saying that it's could be about stress, anxiety, depression. It could be about our occupation, our relationships, the poverty in which we work and live. And now we're really hooking into the social determinants, aren't we, about how they are affecting the way we eat and move, and possibly bringing in a lot of other lifestyle factors too, like why we're smoking and using substances, etc., and how that leads to obesity and diabetes. And then we say, well, so why are we stressed? Where's the anxiety coming from? Where's the workplace issues coming from? And then we just keep going upstream till we get to the distal upstream environment. What is that? Well, that's, that is the environment in which we live, are born, work and play, if you like, and grow. And it's our social economics, it's our physical and political and economic environment. And it's from here things like, well, if our economy is bad or if we're embedded in racism, that downstream we increase our stress, our depression, pressure on our relationships, which leads to poor diet, inactivity, poor education, etc., which leads to obesity, which leads to diabetes. So in lifestyle medicine, if you like, we don't just want to work. Yes, we do want to develop the skills and practices that improve this at management level, but we, as a movement of clinicians, want to look at all of this. We want to be advocates for upstream, and we want to do the research and get to know how to integrate all this knowledge of the medial and proximal determinants into our practice. And that's what we do. And that's what we try to do. And so that was how lifestyle medicine was born, if you like, out of a group of clinicians that got together very frustrated with the current situation and wanting to do more with health to turn it into wellness. And so, interestingly, it was born up around my way in Mullumbimby in northern New South Wales, where we got together for the first meetings. And it's grown from just a gathering of 3 people. Our first conference in 2007 was 40. We now have 1,000 people turn out to our conferences. We have 1,000 members in Australia, of which about 400, 350 or so are nurses. And the remainder are either medical practitioners or allied health. And we offer support and courses and guidance and advocacy and sort of how to integrate lifestyle medicine into practice. And why do we need it? Just in Australia, some of the reasons that we are still very active and possibly seem to be failing is because, for example, in the last 20 years, we're seeing life expectancy at birth stalling. Australia took great pride in the fact that we were rocketing ahead with our life expectancy, but in recent years that's stalled, and it's stalled largely on the basis of lifestyle-related chronic disease, and we're not dealing with it, either preventing it or treating it well. And we can see the top causes of the death. If you look through those, most of those have a preventable and a social determinant issues leading to these being the top causes of death. And these can be worked on at all sorts of levels within that hierarchy that we saw before in previous slide.
Professor Stevens,
yes.
Sorry to say that it's a couple of minutes more, but we can go on. Yeah.
Thank you. And we see the trajectory for good health in Australia has stalled as well. So chronic illness in Australia, I won't go on about it. It's big. Health inequity in Australia is also one of our biggest issues. And again, it's in lifestyle medicine we're trying to deal with. And as you can see, we have a bit of a saying which came out of COVID as well: as a nation, we're not well until we're all well. And we see the biggest health inequity within our First Nations populations, and we see all these terrible health gaps that we're aiming to overcome. And one of the initiatives that I want to speak to you before I go is there's many that were coming out of lifestyle medicine, but one of the ones I'm personally working on and seeing great success in is this notion of shared medical appointments, in that we change the way in which a lot of clinicians already know how to integrate lifestyle into practice, but they don't actually know how to do it. So they have the knowledge, but they don't have the way to do it. And what we see is that the conventional way of doing health, if you like, has come from a bygone era that's no longer fit for practice. And so what we're seeing in shared medical appointments is a new way of doing medical or health consultations, where they are done in groups, and they're done in small groups of between 8 and 15 patients. Often there's a clinician, substitute clinician here for a doctor and facilitator. They last about 90 minutes, and they are heavily driven by nurse practice. And I haven't got any time to unpack this, but this is what a shared medical appointment can look like, in that there's the nurse facilitator working with the GP doctor, and in primary care working with these people to deal with their diabetes in ways that wasn't successful doing short one-on-one consultations with GPs. We can do this online. The nurse, practice nurse there is leading this shared medical appointment with the GP online. This is a Aboriginal men's health group doing a shared medical appointment under their house where they meet and feel very comfortable and safe. Shared medical appointment with nurse-led practitioner in child health, working with mothers and unsettled babies. Nurses, diabetes educator who's a nurse, and clinician working with Aboriginal women who are overweight to lose that weight. You can see we're doing this as a group in a gym, in a scenario where they all feel safe, rather than one-on-one consultations where losing weight just wasn't working. In this scenario, this is working. And these are often nurse-driven and nurse-led. We're doing a big project up in East Arnhem Land at the moment in Northern Territory, where we are transforming the way clinic health is done outside as a shared medical appointment, driven by nurses and accompanied by GPs. And lots of evidence to suggest that this works really, really well. And one final slide to look at a specific initiative that was done, which was reversing diabetes in Aboriginal women, where we used CGMs, clinical glucose monitors, an Indigenous diet program that was invented by the participants themselves, embedded in the shared medical appointment program over 8 weeks, and magnificent results showing of 25 women that finished it, 18 had significant reductions in their blood glucose. 7 were in complete remission by the end of the program and remained for more than 12 months, no longer requiring medication for their diabetes. This is all based on a nurse-led shared medical appointment with Aboriginal women. And APNA, for example, are really taking on board the notion of lifestyle medicine at the moment, because they see it as a way of bridging the gap with whole person care and giving the practice nurses, if you like, greater scope, or using their scope in a better way to feel more satisfied with their work and to have more impact on their client base. I know my time's up, Priya, so I could talk for the entire symposium about all this. So I'm glad you're there.
We could listen to you all day as well, John. This is fascinating stuff.
Okay.
Really incredible. Yeah.
I'd love to talk with you all more and unpack the idea of the shared medical appointment, because it's really quite a dynamic, innovative way of working with the social determinants of health and impacting that all the way through to the clinical care. So thank you for your time, and thank you for allowing me to present this, and I'll be here for questions at the end.